Hi, everyone. Welcome. I think we have one attendee, Robin Lenahan. Welcome. Let's just see if others will join us. We tried to get, I think, here a couple more people joining us. Welcome. Sasha, Mamsala, I think everybody's coming on board slowly. So let's see where it goes. 2 seconds.
Yeah.
Good. Thank you. Welcome. Welcome. Well, let's get started. My name is Shabir Musa. I'm a family physician in South Africa, in Soweto. We're very privileged in getting a representative of AMREF, and I'm sure that George Kimathi, as a senior manager within AMREF, will share a little bit more about his role, and we'll take it step by step. So, George, thank you for sharing. You've got some slides up. I think the key questions which we'd like to answer, and you can proceed and we'll see if there are any outstanding questions. Essentially, we want to know tell us more about AMREF and the work it does. And I think particularly, what it's about, but particularly want to know what work it does in primary health care. And then from there, if we can talk about your thoughts about AfroPHC and how we might take this project forward. So with that, thank you very much. I'll hand over to you, George, and you can share your screen and we can proceed.
Okay, thank you so much, Shabir. I guess you can see my screen. I hope it's clear.
Yes, I can see it very well. Thank you.
Thank you very much. So, and thank you so much for having us this morning for some of us. And hi, everyone, and welcome to this discussion. My name is George Kimathi. I'm the Director, Institute of Capacity Development at AMREF headquarters in Nairobi. The Institute is responsible for capacity building initiatives across the whole organization. We are leading pillar 1 of the strategy, and we work very closely with AMREF International University and a couple of other universities across Africa and outside. So I'll share for a few minutes what we do at AMREF, as Shabir said, our work in primary healthcare, which we do a lot with so many partners, maybe some of you, and then some thoughts on AfroPHC, and then we'll open it up, I guess, for question and answer and discussion. That is our promise to the African people, is basically to work with communities to bridge the gap that exists, of course, like most of us, I guess, do, between communities and their systems. Appreciating that primary healthcare is about communities, is about empowering communities, about putting communities at the center. That is what we've done for years, and that's what we commit to continue doing for years to come. That's a quick slide just giving us an overview of AMREF for those of us who might not have interacted with AMREF Health Africa. We are based at the headquarters in Nairobi. We are now 63 years old. And our headquarters have been in Nairobi for all these years. We have 10 offices across Africa, specifically, from down south, South Africa, Malawi, Zambia, and then central part of Africa, not central, southern really, part of Africa, Uganda, Tanzania, Kenya, Ethiopia, huge programs in those countries. Naturally, because we started in Kenya those many years back, so we've naturally grown within East Africa very well. And also we have a presence in Senegal, Dakar, which is a hub for our work in Francophone West Africa, but also enables us to do work in most of West African countries. As you might notice in my map is there's some bit of red color in Canada, in USA, and a couple of countries in Europe. We have offices in all those countries, as shown, which assist us to grow our partnerships and networks with many institutional donors and foundations. We reach about 12 million people every year, and our budget fluctuates around to plus minus 100. Last year we did over 120 million. We have about 1,500 staff spread across Africa, Europe, America. And we have 3 subsidiaries that I would like to share with you. One is, of course, the oldest entity of AMREF, that is AMREF Flying Doctors, which still does charity work, but largely it's now a commercial entity owned fully by AMREF Health Africa, and the resources that we get from there is a proud back to do more work with the communities. 3 years ago, we started AMREF International University, which is an accredited university by the Commission for University Education in Kenya. This is where we are doing a lot of work in academic training for young people and in-service colleagues in courses that are purely health sciences related. We also have AMREF Enterprises, which assist us to do work that is able to bring in some resources to do more work with the communities. We are very conscious of our context. We keep challenging ourselves to program as much as possible with communities and appreciating that the context that communities find themselves in, even in different parts of the countries where we work, is always different, and therefore we have to put them at the center. These are numbers that most of us will easily identify with in terms of the challenges of maternal health that we face in sub-Saharan Africa, and child health, of course, and all of us are aware of this. And this is the context within which we find ourselves, besides other details, social, cultural, and such. So we appreciate as we work that the healthcare system, in principle, is designed to provide healthcare, to provide health services, but then we realize that in practice, it's largely a health care system, not a health service system. And therefore, we see a lot of discrepancies or gaps between the supply side and the demand side, where demand for all of us who are pro-US PHC appreciate that communities need to be informed, need to be empowered, need to be engaged for them to take charge of their health. And therefore, as AMREF Health Africa, we exist to close that gap between the communities and the conventional system. And we are very happy to do that. And 2018 to 2022, we have a global strategy that guides what we are doing. That strategy is anchored around 3 pillars, and I will discuss that a little bit as we move forward. Pillar 1 looks at training, or the whole question around human resources for health. And I'll get into a little bit detail later, but this is where we are doing a lot of work in training community health workers, frontline healthcare workers, nurses, nutritionists, doctors, public health officers, using digital tools, but also one-on-one trainings, face-to-face trainings. Pillar 2 is around increasing access to quality healthcare at the primary health care, of course, PHC level. And we do this in a very integrated way, as I will share with you shortly. And then Pillar 3, we challenged ourselves to get serious into financing, and trying to get into innovative solutions that can increase investments in health, of course. That's very important. That's why we do a lot of work in to push for UAC, for social accountability, building community capacity to engage governments, and also service providers for quality, for accountability, financial inclusion, and all that. As you can see down there, we have a couple of themes that are cut across all these the 3 pillars, and one is appreciating that gender and inclusion is so important. Of course, policy and advocacy, very, very critical, and certainly generation of evidence that is able to inform policy, that is able to inform practice, but also to be able to come up with models that increase access to care at PHC level. If we take just a minute or two to dive deeper a little bit into human resources for health, because then when we look at the 3 pillars, then we structure ourselves in 3 or 4 thematic areas, broad thematic areas, and one of them is human resources for health. Here we do a lot of work at PHC level to build capacity of healthcare workers. When I say healthcare workers, I mean from community health workers to nurses, to midwives, to nutritionists, for all frontline healthcare workers, to even doctors in certain areas. And we do this to individuals, definitely, as perhaps most of us might be doing, but also we appreciate that there are institutions where these people go for training that are so critical. And therefore, we do a lot of work to send them those training institutions, whether it's nursing schools. We work closely with many medical schools to train, to build capacity around pedagogy, increase their capacity in terms of training equipment and facilities. Where possible, we also do a lot of support in virtual training capacity for these institutions. And then we do quite some work also in human resources for health management. By this I mean a lot of engagement with governments, both at national level, sub-national level, and also regional level in conversations around how we can deploy resources, human resources at the lowest level, lowest level CWs and from other frontline healthcare workers, how we can motivate, how we can incentivize, how we can retain them more in those facilities, and of course systems that are used to manage them, HRIS and all that. We appreciate that leadership management and governance is a core area now in the healthcare systems. And so we do a lot of work in LMG. We have some partnerships that enable us to actually work in close to 30 countries across sub-Saharan Africa with training institutions, building capacity of colleagues in ministries, both national and sub-national levels, in providing appropriate leadership and management to colleagues and to the systems. But also, as I mentioned earlier, we do a lot of work in human resources for policies, again, generating evidence and supporting ministries to implement appropriate policies for HRH. That is our journey. That has been our journey in human resources for others. You can see, as I mentioned earlier, we were established in 1957. We did a lot of work flying doctors and nurses, medical personnel to communities, to villages, OCS. But as time went by, in 70s and 80s, we did a lot of work with the communities in through radio programs, training communities, radio programs, creating awareness, health education, health promotion through radio. 80s and 90s brought opportunities to us to do a lot of print-based distance learning to health professionals in different parts of Africa. But from 2000, as I mentioned, as I'll share just now, is we moved a lot to taking advantage of the technological advancement that's happened from that time to now, and therefore currently we are doing a lot of work that is digital based. Some of the tools that we use currently to train and to ensure that we reach the last mile in our training is an app that is called Jibu that is linked to our eCampus. This is a smart mobile solution which can work both online and offline. We've used it in a couple of markets now, Kenya, Zambia, Malawi. And this enables us to ensure that we are able to reach a nurse, a medical professional who is working at a primary healthcare facility or level, and they are not able to get to urban areas for training, or perhaps even afford to get to a workshop or an institutional training for them to acquire some of the skills and competencies that they require to perform. And this has been really, really useful. These are some of the courses that you'll find on our eCampus platform. Very basic, very useful on diarrhea case management, on pneumonia case management, a couple of others, of course, on diabetes, and a couple of NCDs, and many, many more. LMG, as I said, leadership management and governance, and a couple of others. Then at community level, as I said, communities are the center of what we do. We have a platform that is called LEAP. This is a mobile-based platform app that we use, which uses both text and voice. And in many languages, we've used English, we've used Swahili, which is spoken widely in Eastern Africa. It allows for a lot of collaboration between or among the community of volunteers, and therefore a lot of peer learning and sharing of knowledge, sharing of information. It allows for measurement. You can assess the performance of community health workers as they work with communities. But also it allows for lots of interaction between community health workers and their supervisors. It's the community health extension workers, which then means they can be mentored, they can be coached, they can be supported as they reach out to communities with health promotion, messaging, awareness creation, and all that. We've used this now during this COVID period to train close to 50,000 community health workers. So quick deployment, easy to reach. Now with social distancing becomes a very, very important tool and it's coming handy during COVID. We've rolled it out now in Kenya for the last few years. It's now available in Malawi. We are using it in Malawi now, and currently we are rolling it out in Ethiopia, which is really, really exciting. And another program area that we focus on very, very keenly is RMNCH, and that's a huge area for us. As I mentioned earlier in an earlier slide, the challenges of maternal and child health and neonatal health in Africa is huge. So this is an area that we do a lot of work, largely working at community level, facility level, and also, of course, looking at the neighboring environment that will make it easy for us to work, but also, most importantly, making it easy for communities to access care at primary health care. And so we work with the communities to improve their practices, but also encourage health-seeking behavior for them to access quality RMNCH. So we train community health workers a lot. We mentor them a lot using the tools as I indicated earlier. We do a lot with them to ensure that they're able to reach communities, to reach households, and provide health services, whether it's IT and distribution, whether it's rapid diagnostic testing, and also helping them to form structures, whether it's a community-based structure that outlives the programs that we do. And that links, of course, with the conventional health systems, the facility level and up. Then at facility level, we also do a lot of work, improving services and therefore training providers at that level, providing them with the equipment and basic tools that they need to function, supporting strengthening of health management information systems and emergency preparedness. As I mentioned, as much as possible nowadays, using the tools of our time, and that is digital platforms that are available to do the trainings, and as much as possible, ensuring that level 1, level 2 service providers stay within their facilities and provide services to communities as much as possible. And of course, a lot of work in policy and regulations and such at national level, but also in some countries where health is a devolved function, we do a lot of work with the county governments. I just wanted to say that we appreciate that across the African continent, and I guess in Asia also maybe, that 60+% of our population is under that 5 years. And therefore, when we talk RMNCH, we cannot ignore the fact that all of us have to challenge ourselves to program with and for youth. And therefore, we have an initiative that we've been doing for the last 2 years, trying to mentor and support youth advocates so that they are able to push for access to health services. We know there has been initiatives, of course, to establish youth-friendly centers and all that, but we are not very sure that they have been able to deliver what needs to be accessed by young people. We want them to be at the center of driving the services that they need to access, driving how they are provided, and driving measurement of satisfaction. That's our priority. About 2,000 young people now have been reached in Kenya, and we are expanding this to the region moving forward. As we all know, PHC is about communities, is about needs that communities identify with. I quickly wanted to highlight one social cultural challenge that we face in Africa, of course, around FGM. So we have a model that we've developed with the communities that is called alternative rite of passage for young girls in Kenya, in Tanzania, where we work with the community leaders and cultural leaders to take young girls through a 3-day training on SRHR and norms and values and self-esteem and life skills such as leadership and good grooming and all those kind of things. And then they graduate, and community elders make public pronouncement against FGM. What happens is that these girls then have a chance to go to school, high school in most cases. We've seen that, actually, we've done some research around that, and we've seen that contributing a lot. This is so important because we know that there's a correlation between the levels of education in most communities and definitely maternal and child health outcomes. This has been proven across. And that's just an image of a graduation ceremony that was taking place one time in one of the communities. And then the other huge program area that we do a lot of PHC work is on disease prevention, control, and management. And again, we structure it around 3 core areas around community. Again, focusing on health-seeking behavior and practices, and of course, communities accessing and utilizing quality services at community level and also at level 1. So we do a lot of support to community health workers, training them, equipping them, motivating them, pushing for their costs. We've had a campaign to lobby for communities to be incorporated, to be integrated within the health system, and to be put actually on payroll of governments. And some sub-governments and some subnational governments have started doing this. We do support communities so that they're able to render services to communities at that level, but also strengthening the structures at community level for them to be able to work. So services, the structures, but also building capacity of community health workers themselves and equipping them to be able to move. So equipping here means, of course, the basics, whether it's a simple bag, whether it's a tool that they need, whether it's recording materials that they require, whether it's gumboots in communities which have to operate in not so easy environment. We do all that to facilitate them to work, which is so critical. Then at facility level, lots of strengthening of the facilities. Sometimes it means you get to a level 2 kind of facility, a dispensary, a clinic deep in the villages. It doesn't have basic sanitation facilities, it doesn't have a basic waiting bay, just the basics. And we work together with the communities, with the facility in charges, with the facility management committees to ensure those kind of infrastructure, basic infrastructure is available for such a facility to provide services. And therefore, and besides that, of course, building capacity of the healthcare worker at that point, as I mentioned earlier, trying as much as possible to use technology so that a healthcare worker who is based, say, 10 kilometers, 20 kilometers from the nearest market or health center doesn't have to come to the health center for face-to-face training. They're able to get continued professional enrollment opportunities wherever they work. But also we get sometimes into supplies, basics, materials, equipment, and also health management information systems. And of course, policy, as I mentioned earlier. And just to say that quickly, that around this program, we do a lot of work in malaria. Again, integrated, we integrate it as much as possible and use IO systems strengthening lens in whatever we do. So lots of work in malaria, supported by a couple of partners. We are the principal recipient for Global Fund TB and malaria resources in Kenya. So we've worked with CSOs to strengthen this for many years. HIV/AIDS, of course, with a couple of partners, USG and many others, and TB, of course, and also non-communicable diseases. We do a lot of work in that, not to mention also definitely pneumonia, diarrhea, and many other diseases that we integrate within what we do. And then the other core area of work that we do, PHC work, is water, sanitation, hygiene, and neglected tropical diseases. We've done a lot of work for many years in trachoma, in artidiosis, and all that. And this is ongoing in Kenya, in Ethiopia. We've done quite some work in Malawi. And South Sudan, of course, there are a couple of entities that we work in. So under WASH and entities, we cluster it around 3 areas. That's area 1 is on increasing access to sustainable WASH services. This basically increasing access to safe water, access to sanitation, access to health promotion that's around hygiene and such. So we do a lot of technical capacity building to public health officers, to community health workers, and to frontline healthcare workers who work with the communities around this. Work very closely with sanitation committees, some youth committees in some communities, whether it's informal settlements or rural communities, but also water management committees in many communities. So cutting across. And as I said, sometimes we get resources to do WASH facilities in communities, in schools and markets and such. But also we've we do quite some work in menstrual hygiene management, so very integrated, and appreciating that you can't do WASH without appreciating the challenges that we are facing because of climate change, and also integrating access to safe water with the livelihoods and kitchen gardens, and using water for multiple use of water for animals, for food production and such, cleaning and all that. Then enabling environment, as I said, we also do a lot of work there in lobby and advocacy, so that we have the right regulatory frameworks to support access to WASH and NTDs, and then accountability, of course. I just wanted to share one model that we've been implementing for the last 3 years, which is at community level, and which shows the need to integrate PSC work, because I don't think you can achieve PSC if there is no multi-sectoral collaboration and integration. It's called Finish Inc. If you go to if you search any site, you see Finish Inc. Finish stands for financial inclusion, improves sanitation and hygiene. Inc. is in Kenya. We did this since 2013, 14 or thereabout. And this uses a diamond model where you have communities working with governments, and then financiers, that's the banks and microfinance institutions, and then businesses. So we've triggered communities to appreciate the need for improved sanitation. And then financiers have developed loan products for communities, and loan products specifically to improve sanitation facilities. Of course, then governments come in to ensure we have the right laws and regulations that facilitate business to thrive and financiers to be able to provide this kind of loans. And then businesses, masons, hardware shops, and aggregators and all that, human waste management, small groups and such. So by start of this year, local banks had issued, in Kenya only, local banks had issued slightly over actually 10 million in loans to communities for sanitation improvement. And these are loans that are not subsidized by any donor. The donor gave us just seed money for us to support the financiers to develop their own products, and also some little resources to do the mobilization, and for community-based sanitation promoters to promote safe sanitation, and to show the link, of course, between sanitation and all the outcomes that we all know that you will always see in communities. And this has been very successful. We've been able to see plus upwards of 55,000 toilets being constructed in 3 or so counties in Kenya, which has been very successful. And we pitched this with the MacArthur Foundation, and if you check a bit, you see that this particular model is now listed for the 100 million MacArthur Foundation Award. So it's top 100 change. That you can check and see the details. But it's because it's able to bring communities, bring financiers, and businesses together in a very PSC thinking, and at a very community level, and lots of ownership. Just wanted to speak a little bit about our work in UAC and driving and supporting the drive and the momentum around the universal coverage. And wanted to say that AMREF is a key player, and we are very happy with the role that we are able to play with the colleagues within the sector, of course. Both at across from global level UAC 2030, working with the partners at that level as co-chair of UAC 2030, at AU, working with the colleagues at AU, but also in a couple of other countries, we work very, very closely with the governments to push the cause for UAC, appreciating that actually primary health care is a basis, is a driver, is a key driver of UAC, and that you cannot separate universal health coverage and that's with the primary health care. So we look at the core pillars of UAC, the quality, the accountability. As I mentioned earlier, lots of work that we are doing within the programs around accountability, around quality of care, pushing for quality of care at primary health care level, but also equitable access to care. Communities that are not reached, NTDs, WASH, and all that. And of course, looking at youth and marginalized populations, and of course, financial protection. So we are always challenging ourselves to look for models that are able to push for more resources within the health sector, increase investments, but also for models that deliver greater efficiencies in strategic purchasing and such, and building capacity of healthcare workers and health leaders in providing appropriate UAC leadership in the sector. So just wanted to share this slide as an example of some of the initiatives that we are doing in supporting universal health coverage, specific initiatives. So this is the strategic purchasing Africa Resource Center SPAC. We are hosting that at AMREF headquarters. It's a partnership between AMREF South Africa and Resource for Development, supported by Bill and Melinda Gates Foundation. And the key things that we are looking at here is building capacity of country teams to engage with the governments and other players in strategic purchasing. The question around where to buy, what to buy, how to get the best price, how to increase efficiencies. That question is so important for delivery of UAC. I mean, in the context of the limited resources that we find ourselves with in most of the African countries. And so we are engaging with the country teams. We are using coaching and mentoring as an approach to build that capacity, or to trigger that capacity in some of the countries, and to ensure that capacity is shared within countries, in country, but also across the borders, definitely. We know we have colleagues across who are able to support players in different markets, but also ensuring that there's sufficient knowledge management that is happening, and convenings that then enable colleagues to learn from each other and to deliver this. As you can see from that map there, we working with a couple of colleagues within the civil society, a couple of universities, Makerere there, Kemuri in Kenya, Ifakara in Tanzania, Rwanda, University of Rwanda, School of Public Health, and of course UCT in Southern Africa, and a couple of others in Benin, West Africa. Why AfroPHC? We are very excited to be part of AfroPHC as an organization. We see AfroPHC as a crucial voice for UAC in Africa. As I said earlier, we cannot discuss universal health coverage in Africa without discussing primary health care. So we see a convening of practitioners, academia, champions of PHC as a way to realize UAC in Africa, looking at our unique context that we operate in. Two, just a few thoughts that I thought I would share with us. Two is a valuable convening. AfroPHC is such a valuable convening to ensure that we all have a platform where we can share knowledge on PHC, what is working well, where we are failing, and where we can learn from each other and do more for African communities. I think that is so important. The fact that we have a platform, the fact that we can convene is so important. But reflecting a bit on COVID-19 and appreciating that we are in the post-Astana era, quote unquote, I see AfroPHC as a driver to ensure that the Astana conversations are realized, but also learning from the experience that we are seeing in COVID-19, where we have actually pushed action to communities. Communities to ensure everybody is wearing masks. Community health workers pushing for social distancing. Community health workers pushing for hand washing and sanitizing, and households and individuals owning their health. I think we cannot have a better case for primary health care than what COVID has presented to us now. And finally, the fact that AfroPHC is a convening of diverse stakeholders is in itself the key basis for us to support it, in that we cannot achieve primary health care without all these stakeholders, all these diverse practitioners from academia, from government, from civil society, working together and pushing for primary health care. Shabir, if you allow me, I'll stop there and thank colleagues so much for their time, for listening to me. I'm so happy to share that with you and looking forward to respond if there are points that require clarification or if there are questions. I'm happy to share and respond to colleagues. Thank you very much.
Thank you, George. George, that was, you know, I've always been very impressed with what is happening with, I think you can just stop sharing. Yep. Just generally what happens with AMREF. I mean, you guys are an amazing bunch of people doing amazing work, and we really appreciate you. So please tell the team, we really appreciate this. I think that if we're looking at, I think there's one question, and perhaps I can start with that question and then we can go on to some issues I'd like to raise. I think the one question is, I would like to understand how AMREF maintains participant engagement in online and offline training, reducing attrition. Any thoughts about that? I think that's a very specific question. I think you were talking about your online approach. Do you all have sort of discussion groups and forums, etc., or is it tends to be asynchronous type of management of it? Perhaps you can just give some insight into that, anonymous attendee.
Yeah, thank you, Shabilon. Very good question. The AMREF campus does three things. One, it's responsible for design of the courses or the programs that we offer virtually. And then two is actual delivery. And three, which is so important, perhaps speaks to your question, which is really good, is learner support. So first of all, in terms of the infrastructure, yes, it allows a lot of interactivity. So group chats, even the LEAP platform that trains community health workers allows a lot of interactivity. So we organize community health workers in small groups of say 5, and therefore there is a social pressure to complete whatever course or units that you need to do. And the same case applies to when we are training frontline healthcare workers in far-flung PHC facilities. We cluster them in small groups so that there is some better pressure for them to complete. But of course, we also use the platforms to train students. The AMREF International University students use the same platform. Those who are doing nurse upgrading from registered community nurse to BSN do use the same platform. So for pre-service learners is much easier, of course. But also for in-service learners who are pursuing an academic program, again, it's much easier because it's examinable. But for the in-service who are doing for general continuing professional development, then we cluster them in groups. Maybe the last point that I would like to share, Sabine, is we ensure that the courses that we offer are also CPD learners. So we design them with the regulatory bodies. And therefore, most of the learners who get to our platform to do the courses, they do them because they want to earn CPD points. Therefore, there is a motivation attached to the course. Yeah, thank you.
No, that's very useful. Let me just get some of the other questions. I think Robin Lenahan wants to speak, so maybe we can give him that little chance. Let me just see how we can try and help him to speak so that we've got another voice. Has he changed his mind, Robin? Okay. So anyway, we've got some other questions. Jessica Lenahan Lawrence, I think you can read the questions as well, but could you please elaborate further on the mobile training? For example, is it a manual questionnaire video? How does the mobile training work? Is it the same as a web-based page type of training, but suitable to the mobile platform? Any thoughts around that?
Yeah, sure. There are two. One is if you check a bit on the website somewhere, you find that later, I guess. And thank you for the question. There are two. One, we have the LEAP, LEAP, which is a mobile-based, of course, learning platform. Currently, it's able to do both the basic and smartphones. So basic phones means then, again, we are staying faithful to PHC because we're asking ourselves, if you have a community health worker who is somewhere 500 kilometers from Lilongwe in Malawi, then they have no access to smartphones and the internet and such, and therefore the basic phones ability for it to use a basic phone is very critical. So we have that, and it is able to use both voice and text. So voice and text.
No video. You're avoiding video.
Yes, very light video. But now we have upgraded it, but it's available in both basic and smart. So the upgraded smart platform is able to do more, of course. The multimedia, you can use video, you can use basic simulations and all that. So which is working quite well. Then the other one that we've developed, the app that we've developed recently, it's called Jibu, Jibu. Jibu in Swahili is answer. That is linked to the AMREF campus, and that is more available to healthcare workers, nurses, nutritionists, doctors, and such, and use it to train them. And that one uses on his smartphones, not the basics.
I'm very impressed, and I'd love to, I know that you've basically allowed us to get access to the leadership and management course, leadership management governance course that you mentioned. And I think that's really great. I'd love to explore. We've had lots of take up. I'd love to get your thoughts on whether that's been too much, too little, and I think just explore that with Jibu as well. We can get down to clinician level, that in the multidisciplinary team, that we can make it available, make them aware of it, make them know how to do it. So just with some thoughts on that, and then maybe we can get to the other questions. There's plenty of time. I think we'll get to all the questions. Just if you can respond to that. Is it available that we can look at that, right? So we can talk more about it. I think one question that is here, which is, I think, useful, is the question of models used in evaluations. So essentially, how do you actually make an assessment? What sort of evaluation models do you have? I think it's more about assessment than necessarily evaluation. It's about assessing the transfer of knowledge. How do you manage that on the online platform? Just as a general question. Yeah,
that's a good question, Shabil, and thank you for that question. It's very tricky for what we do for academic programs. The students have to sit the exams in a designated exam center. So, for instance, if you nurses, say, let me give a practical example for nurses who are upgrading from a diploma to a BSN, or a few years back when we were upgrading nurses from certificate to diploma, they would have to sit in a designated exam center for control and credibility of the results, of course. That one we have to do that way. But for other continuing professional enrollment courses, because the Liga is not as much, then the control is done largely within the system. We have a way to check that, but of course it's not watertight necessarily. But the risk is very minimal, because if you are doing say a course in management of Doria and you are a nurse, then of course the system is set that after every unit you can't go to the next unit before you pass exam for one module. You can move to the next module, which provides a bit of control. But then that doesn't mean that you can't sit with a colleague and then you answer the questions together. You know what I mean? So that's exactly why we can't do that for students. but then the most important thing for us is that what do we want a community health worker to learn? It's not necessarily so much about the test, but about the knowledge, about the competency. So if a nurse is doing a CPD course, then the most important thing is not whether they discuss with a colleague and he or she is able to pass and go to the next module. Our joy is that they have been able to learn a couple of skills that are relevant to what they do. But for students, we are cautious, so they have to sit in a designated exam center.
I would suggest that colleagues go have a look at the course and join it and see, in a sense, how the evaluations occur. I think invariably with an online type of approach, Knowledge is one thing. Skills and practices or behaviors are quite difficult to manage. And one has to look at some sort of combination. And it can be done even in an online platform where you're getting sort of work done. I think in evaluation, it's moving away. One has to have enough in the way of samples of test, in an MCQ, enough of the questions, in an OSCE where you have enough of those sort of stations, and increasingly those are not as important as sort of workplace-based assessments, which I imagine is something we can look at with you to see how it can be improved. So Absolutely. Let me leave that. I think thanks, George, for that answer. I think just quickly going to some other questions. There's Elise has asked questions. I'm going to combine it about whether AMREF does research and do they offer training in generally in research competencies.
Yeah, thank you for that. Yes, Shabir, we do. We offer actually training in research, and why we established AMREF International University is because we see a huge opportunity for the university professors and other senior colleagues at the university, providing that particular support to the NGO piece of AMREF. So we have a huge pool of programs that are learning in communities, and then we have these professors in the university who assist us to do that research. So yes, we have an offering in terms of yes, and lots of collaboration with the AMREF University research.
Great. Yeah. Great. I think the question from Joseph Anna from Nigeria, I think perhaps we can combine it. Moto from I think Nigeria asked, is there any plan to extend into Nigeria or other parts of Africa? I imagine you've covered most parts, but maybe you're missing Nigeria. But anyway, I think that question. And Joseph asked the question, you've been around since 1952. What's the trick? How did you survive?
Good question.
Joseph, about people lasting more than 5 years.
Yeah. Thank you, Joseph, for that. And colleagues who asked a question about Nigeria, we our strategic countries for now are Zambia, Malawi, Kenya, Uganda, Tanzania, Ethiopia, and Senegal. But we have a presence actually in many other countries through collaboration. So yes, Nigeria not necessarily to establish an office, but we are already scouting for partners in Nigeria whom we can work with. And we already worked with the Lagos Business School and a couple of other training institutions to do both the leadership management and governance and a couple of other things. So yes, Nigeria is on our radar. Not as a strategic country, but as a potential country to work with the partners. How have we survived since 1957? I think what we've learned is PHC Shabil is a huge area. So from 57 to today, we've never changed course. It's about communities, it's about community need, it's about building community trust, which then gets to governments in most of these countries believing in AMREF because we are so close to communities for many years. I think that's a trick. And then of course donors appreciating that we have our hearts are very close to communities' needs and trust.
And I think that's really what I loved about our engagement, is this commitment to community. And I think that's one of my questions. How do we get community leaders and community health workers participating in the AfroPHC discourse more? And I don't know whether you think, because I feel, in our core group, there are a lot of professionals coming on board. I even want you as AMREF to be sort of more vocal, but I'd really appreciate if we can get some key people, even on the Google group, to sort of share their stories, which I think you've talked about as being so important in AfroPHC. So we're going to push you later, but here's the last question. Is apparently choose, I imagine that's community health workers are vital. What is the role, I think, of a medical doctor? What does the medical doctor play as a role? Any thoughts about the team and configuration of the team? I think that's one of the problems that family physicians have had, is that, everybody says, oh, we don't have enough doctors, so doctors stay in hospitals, we'll do primary health care with everyone else. And as family physicians, we're very unhappy with that, because it's a combination, and we feel that there's a mix of different personnel that are important, but the doctor needs to play a role. Anyway, perhaps I'm answering it for you, but go for it.
No, that's a tough question, Shabil, of how doctors can play a role. But I think there could be, and we need to push for that space in the policy, because I think there is a role. It's a balance. It's a balance between the physician sitting in a consultation room or in a facility which doesn't necessarily directly engage with the community health workers. There's a balance between that and supporting community health workers. I think the most fulfilling part of work sometimes is when you interact with community health workers and interact with what they do with communities every day. And again, it's a back to balance. I'm asking myself, how can I, as a physician, ensure that out of my 10 hours, 8 hours, I commit 2 hours to actually do work that links with the community health worker?
Well, that's exactly right. And I think as a family physician, I get challenged by family physicians and primary care doctors, not looking at beyond their consulting room. And we're pushing the idea very strongly, which is something we want you to be really partner and push the issue as well. How do we get the family physician much more out in the community? As a discipline, we're very keen on community-oriented primary care. And as an example, in Shawelo, we work very strongly with the community orientation, very strongly in collaboration with community workers. It doesn't mean we necessarily are roaming the community every day, but there's tasks involved in engaging and linking the team and the process and the data and thinking that whole thing through.
Absolutely.
Which I think many family physicians feel unable to do, but it's more about perspective and frame of thinking in their consulting rooms than necessarily, somehow they need permission to go into the community. Nobody really needs that, even if anywhere, you just have to get going. And I think that passion you have, we really would want that to be part of this mix in AfroPHC. So I think that's a great, part of our partnership. And I want to just ask you 1 or 2 questions. I see most of the participants have answered their questions. I'm going to just maybe open, some statements and some questions in between. I think it's really great that in terms of your focus, you're really looking at social determinants of health. And I think that we need to have that conversation going forward. I think as to how we advocate in different settings, how do we get the different the PHC team understanding what they can do about social determinants of health. I think that you're engaging with community health worker reps. I talked about, we really want them to be in this conversation broadly. So if we can get them to join our Google group, join AfroPHC, you need to facilitate that. So I really want you to reach out to your network and say, join AfroPHC, bring on the board your voice and say what you're doing. And there's, it doesn't need to be, we want to make everybody feel comfortable. So I really would want that. I think that, and especially the sharing of resource. I think you have mentioned that it's the value you see, and we really want to do that. So we want to sort of get case studies, and coax that along. So we want to try and go down that road if we can try and facilitate that together. And I think especially community health workers, communities. Perhaps in last, I think the question of UHC, you talked about PHC and the payment methodologies. How might we participate in the conversation in Spark as practitioners right at the other end? You've got the Spark trying to bring together people high up in government talking money, and now bringing us as clinicians. How do we bring them together? I think Nat was going to try and build that, but we just haven't. Nat's left, so we've not been able to take that forward. What do you think we can do?
Thank you, Shabir, for those comments. I think I would be very happy for, and we already started that now with the COVID, because strategic purchasing is also, of course, high up, but then it is high up for communities, not higher for people who are seated in headquarters, MOH headquarters in our countries. It's higher for communities. So I would be very happy to facilitate one of these days a webinar, if colleagues agree, for our SPAC colleagues to, maybe the executive director of SPAC, to join us for a discussion on how SPAC actually can contribute to pushing PHC costs. So how does that conversation that is happening at high up MOH level actually resonate with the push that we have at AfroPHC for primary health care down at community level? How do the tooling? I would be more than happy to facilitate.
Well, that's a great idea.
Such a discussion. Yeah.
That sounds like a great way to take the conversation forward. Yeah. Perhaps lastly, there's a thought, and it's a provocative thought.
Yeah.
COVID's just swept everything. Our brains are just not thinking anywhere else. And in fact, sometimes when we had this webinar, I said, gosh, there were just a few people, and is everybody not thinking about anything but COVID and has got no time to think of systems and issues like that? But I think you pointed out something that I personally think is really important, that COVID actually demonstrates the problem, that health systems are really battling, and primary health care is not equipped. And so if we're going to have this global conversation, we need to go out there and say, COVID tells you a lesson, that if you don't strengthen primary health care globally, we're in trouble.
Yes.
And we need to actually punch above our weight to say, as an African collaboration around PHC, we think the conversation needs to swiftly move towards, the question of global solidarity. And I wanted to posit an idea, and just your thought briefly in closing would be useful, is that we have this aid attitude, aid other parts of the world. But the whole concept of universal health coverage in a country is about everybody sharing the same, putting the same in, or putting in according to what they have, and using it according to need. Why can't we talk of universal health coverage across the globe? Can't we put it on the table and say, the globe, every country needs to contribute to a global fund, not a global aid fund, a global UHC fund? Is that too provocative?
Yeah, I like that.
You like it?
I like that. Absolutely. The other thing that COVID, and I guess colleagues who are on this discussion will agree with me, what I've seen with the COVID, Shabil, is the other pillar of PHC, and that is intersectoral collaboration. So I was amazed last week when the Kenyan police commissioner, the head of police, was talking about flattening the curve. And I said, come on, everybody now is becoming an expert in epidemiology and public health. That is it.
It's happening, eh?
Yes, that's exactly. You see how the water guys and security and social services and all of us in the health sector are coming together to fight COVID. That is PHC. So the question is, how do we advance this post-PHC, post-COVID? How do we make it happen post-COVID? How does this become the galvanizing moment for us to actually push in a strongly primary health care? That's the point.
Absolutely.
Yeah.
So thank you. We need to make some sort of effort in this regard. I think we need to put out some provocative statement that we need thinking UHC globally, and
Absolutely.
that we should be using the opportunity. I must say, I'm surprised by how many ministers of finance are saying, well, how do we balance health? And they're probably seeing the cost of poor health.
Yes.
Now, that it comes with a price if you don't address it.
Absolutely.
So thank you very much, Michael. I think I've certainly enjoyed it. I'm sure that our attendees have enjoyed it. We really wish you well, and please keep safe. And to all those who are attending this session, enjoy yourself, take care, and please be safe.
Thank
George,
you,
thank you very much.
Thank you, Shabila. Thank you, colleagues. Thank you for joining. Thank you. Stay safe. Thank you. Bye-bye. Bye.